Antoni, how often do you actually have to, if you use monotherapy, anti-PD-1 therapy, how often do you have to stop those therapy in patients because of the side effects?
It's actually very low. I forgot the exact number, but it's less than 5% that patients on nivolumab single agent or pembrolizumab single agent would stop therapy because of side effects. The majority of side effects are manageable with these single agents. There's these low-frequency serious side effects and can be itis from the top to the bottom, as Georgina described. And we have to be obviously vigilant, and we have to have patients informed. And our routine management of these patients is before we get a new infusion, we see the patient, we ask about potential side effects. We have full blood tests, including CBC and chem panel, and we look for any hint of inflammation in the liver or in the kidneys. And then we try to have the patient informed from the start to say, there's certain things that you really need to get back to us, and I think diarrhea would be on the top of the list when we use ipilimumab alone or in combination. And from anti-PD-1 alone, nivolumab or pembrolizumab, I do ask them to inform if there's pneumonitis, if there's shortness of, if there's any evidence of shortness of breath that appears new. But then anything that goes out of the norm that persists, it's a reason to either contact us or come to see us in the clinic.
Now, how often do you have to use steroids for these patients on monotherapy, anti-PD-1 therapy?
The steroid use is also very low. It's less than 5% of the patients. The reasons for using steroids would be most frequently hypophysitis, pneumonitis, hepatitis, and nephritis in my experience. There's occasional neurological syndromes that if we've treated enough patients, we do see encephalitis and meningitis type syndromes, which obviously would require treating with corticosteroids. The majority of patients would improve with these therapies, especially when using anti-PD-1 antibodies alone.
And what about then in the combination therapies, when we have, using nivolumab with ipilimumab, how often do you have to use steroids in those patients?
Well, there we have a lot higher frequency of grade 3 to 4 toxicities. The frequency is over 50% of the patients that have clinically significant side effects. And it's not only the frequency, but the magnitude of them seem to be higher. So if we go over all of these itis in any part of the body that we described, they are going to be more frequent, they're going to be more serious.
And how long do you use the steroids for then in patients? How long do you keep them on steroids? And do you have a certain method of starting the steroids and tapering the steroids for the patients?
In general, I try to avoid using steroids unless I really need to. And in the case of the combination therapy, there's a significant number of patients that really need it. So I would not use corticosteroids for a skin rash that's not life-threatening. We're trying to turn on the immune system to fight the cancer, and we should not try to dial it down at the minimal side effect. With diarrhea, I do the same. If a patient has loose bowel movements but nothing else, I advise to change diet and hydration as opposed to start corticosteroids. But whenever we get to toxicities that are grade 3 to 4, meaning that it warrants a clinical an intervention, then I don't hesitate to start with corticosteroids at 1 milligram per kilogram dosing if it's a toxicity that I consider that's really impacting the patient and maybe detrimental. Some toxicities I'm more worried about with the combination therapy, hepatitis and colitis. I tend to use high doses of corticosteroids and taper very slowly. I've seen reappearance of the toxicity with even when if a week later the symptoms have improved or the biochemical changes have improved. Tapering at that time sometimes has been a recrudescence of the syndrome. So I tend to go slow on the tapering. Some patients we've had to add the second drug that would be for colitis most frequently infliximab. for hepatitis would be mycophenolate. Infliximab would be counterindicated in a patient with elevation of transaminases. But obviously, it has to be personalized and it has to be addressed in a way that we are adapting the treatment to how the patient is presenting and behaving.
I think one of the points about that is, again, for most of those toxicities, we are able to generally taper the patients off of the steroids, probably with the exception of the hypophysitis. That, again, if they develop, again, that hormonal insufficiency, again, patients usually are sort of staying on steroid replacement therapy as far as we know for the rest of their life.
And for all of you, how do you decide when to admit these patients for their toxicities in this setting? Do you have certain standards for that you use for that? Yeah.
So there's this kind of falls into the category where we do have algorithms that can help, and these algorithms are available online, and doctors or nurses that are taking care of these patients can search for these algorithms and find them. But in the end of the day, it comes to just clinical gestalt. And you know when your patient's not doing well with your initial first-line immunosuppression, such as first-line oral prednisone that you can give them very easily available. If that's not working, that's when I start to think about whether or not this patient needs to come to the hospital, because if they're having colitis that's refractory to steroids, I'm worried about its ability to be absorbed, and I'm worried about dehydration, hypokalemia, other problems of ongoing diarrhea in that kind of context. So that's a threshold for hospitalization. And then other types of side effects that are rarer, such as some of the neurologic side effects, such as the pneumonitis. I think more about hospitalization just because I want to ensure that these patients are in a monitored environment such that if they don't improve with our initial immunosuppression, we can continue to monitor them, support them, and then add additional immunosuppression as needed.
The only other factor, if I can add, is also the comorbidities. So, for example, a little bit of diarrhea in a 40-year-old who's well supported and close by is very different to diarrhea in a 75-year-old who has a bit of heart failure and some other things going on. So that's the other thing. So I have a lower threshold for people with a lot of comorbidities, of course, which we all do.